Good morning. Today we are going to read the TB guidelines from the Neonatal Pediatric Guidelines, the Blue Book. Just to continue this topic, so let's start. Okay, investigations and management following exposure in pregnancy. Usually the results of maternal history of TB in pregnancy. So mom got a TB during the pregnancy period. Baby exposure to a close, usually household contact with sputum positive TB. Anyone infected with TB and the baby got contacted with. Okay, to involve correct teams. So that's the main important point in here. How to involve the correct team, how to choose the correct team. Investigations and follow-up require planning before birth of baby. Obstetric team to complete neonatal alert. Neonatal team to discuss with obstetric team regarding placental sampling for microbiology and histology. TB team to alert neonatal team if a woman receiving TB treatment is pregnant, so that this can be planned. So the TB team will organize with the neonatal team, and the obstetric team as well will organize with the neonatal team. So we have 3 teams in here: obstetric, neonatal, and TB team. Neonatal team to feed back to TB team, pediatric infectious disease team on discharge and in planning for follow-up. I guess this is the most important informations to be put in mind for the pediatric clinical MRCPCH exam. These teams are very crucial in the management of the a newborn baby exposed to infected mom, any close contact with TB infection. So it's very important to remember these names very well. So neonatal team to feedback to TB team or pediatric infectious disease team in discharge and in planning and for follow-up. Okay, we have here the diagram. If the baby not at risk of acquiring TB or past history of maternal TB. So if we have a baby, he is not at risk to catch TB, or there is a history, past history of maternal TB. His mom got TB and she got treatment and she is doing well at the moment. He is not at risk. So what we're gonna do with this baby, we're gonna give him a BCG vaccine and we're gonna follow up with him as required for general condition. Well, that's so clear. Okay, let's go to the other side in here. Baby at risk of acquiring TB. Okay, so the other baby is at a high risk of acquiring TB. If we got a baby at a high risk of acquiring TB, so we're gonna investigate this baby. First, before we start investigation, I have to inform the relevant teams, as we have mentioned before. The neonatal team, the obstetric team, and the TB team, and the infectious team as well. 3 consecutive early morning pre-feed gastric washing collected in alkali medium, arranged with microbiologist for TB testing, request microscopy for acid-fast bacilli, urgent PCR for mycobacterium tuberculosis and mycobacterial culture. Chest X-ray plus minus CSF. Additional investigations you need to do plus minus maternal endometrial or placental sample for TB testing. which is AFB, BCR, and culture. So again, if you have a baby at risk or catching TB, we have to inform our teams first, relevant teams. We need to obtain 3 consecutive early morning pre-feed gastric washing collected in alkali medium. I would arrange with microbiologist for TB testing, request microscopy as well, microscopic examination for acid-fast bacilli, BCR as well, and culture. Chest X-ray is mandatory in here, plus minus CSF examination, maternal plus minus maternal endometrial or placental sampling for TB testing, AFB, BCR, and culture. If baby has clinical signs, evidence of TB on chest X-ray or positive microbiology, seek advice from TB team. Or microbiology and or pediatric infectious disease specialist teams and treat for TB. So this symptomatic baby, he has clinical signs, he has evidence of TB on the chest X-ray, the microbiology results are positive. So in this case, we have to ask advice from the TB team in first, microbiology, pediatric infectious disease as well, to start before start treatment. If baby will with normal investigations, so if the baby is doing very well and his all investigations are good, we start, but he has a history of contact, so start isoniazid and add pyridoxine if breastfed. So if we decide to start isoniazid for this newborn baby, we have to add on top pyridoxine if he is on breastfed. Why pyridoxine if he breastfed? Because the formula feed or formula milk containing pyridoxine. So no need to give added supplement of pyridoxine, but he is exclusively breastfed. So we have to add in top pyridoxine for the isoniazid. We have to check the liver function test as well, arrange medication while inpatient, arrange medications while inpatient, GB doesn't prescribe, inform TB team in either situations, will support outpatient care for mother and baby in conjunction with pediatric neonatal specialist team. So if the baby is doing well, his investigations are all normal, we'll start the the isoniazid, we'll add pyridoxine if he is only breastfed, we'll check the liver function test, and we'll arrange medications while he inpatient and admitted. And of course, we will inform the TB team. Okay. Management by TB infectious disease specialist or consultant with special interest in infectious disease. So this box is only for the our seniors. So the TB team, the infectious disease team, they will do this stuff. Okay, it's not our job as registrars. Okay, so they gonna carry out a Mantox test plus minus interferon gamma release assay, which is IGRA, for after 6 weeks of treatment. So so after starting treatment with isoniazid for this newborn baby, the TB team will arrange Mantox test or plus minus IGRA after 6 weeks from the treatment. Okay, if IGRA or Mantox test positive, and that's mean there's induration of more than 5 millimeter in size, so we're gonna reassess for active TB by clinical examination and chest X-ray. If there are symptoms signs or abnormal chest X-ray, obtain respiratory sample, gastric aspirate plus minus CSF for microbiology as above. Treat for TB in conjunction with TB or pediatric specialist. Okay, so what the specialist gonna do? So they will carry out, they will ask for Mantox test plus minus interferon gamma release assay IGRA after 6 weeks from the um, after 6 weeks of treatment. So if IGRA or Mantox test positive, and that's mean in duration more than 5 millimeter or more, so we're gonna reassess again for the clinical examination for the clinical signs for active TB. We're gonna check the chest X-ray again. If there are symptoms, signs, or abnormal chest X-ray, so we need to take, we obtain respiratory samples. We look for a gastric aspirate, CSF plus minus CSF for microbiology, treat for TB in conjunction with TB pediatric specialist. Okay, if this assessment is negative, continue isoniazid with pyridoxine for a total of 6 months. So if IGRA or Mantox tests got a negative results, so in this case, I'm gonna continue my treatment isoniazid with pyridoxine for a total of 6 months, or isoniazid with pyridoxine and rifampicin for 3 months. Okay, if Mantox negative and IGRA not done, request IGRA. So if I have a Mantox test negative and IGRA not done, so I have to ask for IGRA. If Mantox negative and IGRA indeterminate, Mantox negative and IGRA indeterminate, refer child to TB specialist. If Mantox test negative and IGRA negative and baby asymptomatic, stop isoniazid and pyridoxine and give BCG vaccination 72 hours later. If Mantox negative and IGRA is positive, reassess for active TB, treat if active TB, if assessment for active TB negative, continue isoniazid with pyridoxine for a total of 6 months, or isoniazid, pyridoxine, and rifampicin for 3 months. So again, the last point, if we have a Mantox negative and IGRA not done, request IGRA. If Mantox negative and IGRA indeterminate, refer to TB specialist. If Manto negative and IGRA negative, baby asymptomatic, stop isoniazid and pyridoxine and give BCG vaccine within 72 hours later. If Manto negative and IGRA positive, reassess for active TB and treat for active TB. If assessment of active TB negative, the specialist will continue isoniazid with pyridoxine for 6 months, or isoniazid and rifampicin for 3 months. We have a note in the last box here. It is important to inform TB team and consult an infectious disease physician or pediatrician neonatologist with infectious disease interest and microbiology team of all cases for information, confirmation of action plan, and decision on follow-up. All cases of multi-drug resistant and extreme drug resistant TB should be managed in conjunction relevant support from Public Health England and above. Okay, let's move the next page. Important points to consider. Baby at risk of acquiring TB includes mother received treatment for less than 2 weeks, or mother on therapy for more than 2 weeks but sputum smear positive. Mother diagnosed with TB, mother diagnosed with TB in postpartum period, It's better to annotate. So, okay. Mother diagnosed with TB in postpartum period and or after commencement of breastfeeding. A close household contact with sputum positive pulmonary TB. Okay, for all cases of maternal TB and pregnancy, decision whether baby require INH prophylaxis should be made in conjunction with the relevant local team with expertise. For example, TB team, microbiology team, or local or regional consultant, infection disease specialist. Appropriate team will advise in cases where significant exposure, symptomatology, to commence anti-TB prophylaxis or treatment immediately before completion of gastric washing sample. So again, they insist in this guideline to involve the teams as soon as possible to decide what kind of treatment and when you have to start for the treatment, when to start or commence the prophylaxis as well. If starting baby on isoniazid prophylaxis, do not administer BCG at discharge from NNU. Isoniazid will have an effect on BCG vaccine. So this is again very important point. If baby given BCG at birth, interpretation of skin test at 6 weeks difficult, and IGRA becomes essential to distinguish BCG response. Will give the tuberculin skin test positive response and IGRA negative. So that's mean if the baby got a BCG vaccine at birth, the interpretation will be the interpretation of skin test at 6 weeks will be difficult, as the tuberculin test mentor, it's going to be positive and IGRA is going to be negative. Or latent TB, which is will give a result of IGRA is going to be positive. Okay, if treated with isoniazid and breastfed, give pyridoxine 1 milligram per kg per day supplementation. Again, this is a very important point. They mentioned many times in the guideline. Mothers with active phase TB can breastfeed once smear negative after appropriate treatment. If baby treated with isoniazid, check liver function test 2 weeks later. So if we commence the isoniazid for the newborn baby, we have to check the liver function test 2 weeks later. 2 weeks later, we have to check the liver function test. Okay, baby may acquire mycobacteria from an incompletely treated mother, either in utero, intrapartum, or postpartum. Congenital TB transmitted across the placenta or at birth is very rare, but potentially devastating with high mortality. Transmitted when mother has usually undiagnosed, untreated, or inadequately treated disseminated TB with endometrial or urogenital involvement. Okay. Characterized by primary focus in the liver. So how we're gonna know that the mom has a disseminated TB or miliary TB? The endometrium is going to be involved, urogenital involvement, primary focus in the liver, hepatosplenomegaly, and miliary or disseminated picture, including respiratory dissemination and TB meningitis. So this is the transmitted TB. This is the clinical picture of transmitted TB from mom. Primary focus on the liver, hepatosplenomegaly, miliary or disseminated picture, respiratory dissemination, and TB meningitis. Okay. Neonatal neonatal infection by respiratory route from sputum smear from sputum smear positive or negative mother or other contact with respiratory TB much more common. The newborn is highly susceptible to severe respiratory and disseminated disease, including TB, meningitis, and miliary TB. TB, meningitis, and miliary TB. Baby may also present with symptomatic TB if infected by a mother or other contact whose TB hasn't been diagnosed. Consider unsuspected TB even in absence of proven maternal TB, especially in endemic regions. Signs and symptoms may be subtle and atypical in newborn young infant. Gastric washing samples taken pre-feed, usually early morning, are useful as any potential mycobacteria caught by baby's innate mucociliary escalator will be washed into the trachea, bronchi, and upwards, swallowed and present in the relatively less acidic neonatal stomach. Using an alkali solution as the transport medium for the gastric aspirate keeps the mycobacteria alive until tested in the lab. IGRA and Mantox skin test define infection but cannot distinguish between infection and disease. If IGRA, also known as IgT, TB, T-spot, if IGRA not available, Mantox skin test is sufficient provided baby hasn't had BCG. So if we don't have IGRA test available in the workplace, so we have to do a Mantox skin test, but we make sure that the baby doesn't have BCG vaccine beforehand. IGRA takes 72 hours to be completed and cannot be carried out at weekend, arranged with microbiology, immunology laboratory. So IGRA, IGRA test will take 72 hours for results to get ready and cannot be carried on weekends. So Mantox test is faster than the IGRA, okay? And in here we have parent information leaflet for the for TB in pregnancy and for prophylaxis in baby. So these links for the parent information leaflet. We have finished the TB neonatal guideline from the neonatal pediatric from the neonatal guideline book, the blue book. And by the end of this session that we have done TB from both books, I wish this video will be helpful for many doctors, candidates for the exam. And thank you for watching.